And good morning, everyone. How are you doing today? Totally forgot to cut on my studio lights before I went live. Holy cow, what was I thinking? How's everybody doing? It is now, we are getting towards the last couple of weeks of the season, the semester. I hope you are as excited as I am about the end of the semester. Congratulations, uh, Iris. You are one semester closer to whatever vocational dream you had because you stayed in class and worked hard. Hi, Cassette. Wow, look at that. And we have a visitor in the classroom as well, former students stopping by to say hello. Hi, Cosette. It's good to see you. Thanks for stopping by today. This is Iris, my current student, and we're talking about clinical psychology today. So, without further ado, let's go ahead and get started. So, we're going to be talking about Chapter 14, Psychological Disorders. And people seem to be pretty interested in this topic. Now, before we get started, I want you to know that I am not a clinical psychologist, okay? So, I'm not a professional psychologist. Clinical psychologist, I should say. So, anything, if I say anything in this classroom that contradicts what your clinical psychologist, what your therapist says, I suggest you go with what your therapist says, not with what Dr. Roddenberry says. Okay, so Iris, that's going to be kind of the the caveat that I give you today. I'm going to tell you the best I know, but realize I do not have the professional training to be a clinical psychologist. But having said that, I can give you a pretty good introduction to sort of what the field is about in case you're either interested in becoming a clinical professional at some point, or if you need to talk to somebody of that type and you want to know a little bit more about the process. Those kinds of things I can definitely help you with. Okay, so let's go ahead and get started. Now, one of the things that I want to tell you is that the diagnosis and treatment of psychological disorders is, from a scientific point of view, is not that old. Actually, modern medicine is not as old as you would think. You'd be surprised, right? But one of the things that that medicine uh, did first was come to an organized way, a systematic way of, diagnosing and treating medical disorders. When the field of clinical psychology began to get organized at the turn of the 20th century, it became apparent that the treatment of psychological disorders needed to be as organized as the treatment of medical disorders. So the medical model tries to think about psychological disorders. Really, they stem from some sort of dysfunction of the brain and nervous system. So you can think of them as a form of physical illness as well. And so this is, like I said, this represents a jump from the days of Sigmund Freud and even farther back when they thought of psychotic people as witches or whatnot. Okay, so this is a new model where we look at symptoms and we try to look at collections of symptoms. Now, here are some of the terms that you're going to hear when they talk about uh, uh, treating psychological disorders. And these are the same terms that you're going to hear about when you talk about treating medical disorders. And the reason we use them is because they are very useful ways to think about uh, the, uh, the psychological disorder. Now, diagnosis. One of the changes that this guy, Emil Kraepelin, introduced in the early 20th century was this idea of diagnosing people based upon collections of symptoms. Back in the old Freudian days, you would go in and you would get psychoanalyzed by a therapist who would come to sort of a unique judgment about your history and how your history had caused your psychological disorder. Uh, One of the things that modern clinical psychology does is it looks at uh, lists of symptoms. Now, sometimes this leads to incorrect diagnosis or weird looking diagnosis, but or situations. But one of the things that's useful about it is it allows us to sort of look at the variations of disorders that people have and think about them more systematically. So we diagnose based upon collections of symptoms. And when we talk about depression a little bit later today, I'm going to talk about 9 symptoms. There are 9 diagnostic elements of depression. And if you have 5 of those 9 elements for more than 2 weeks, see how that sounds really, really symptomatic? That's how the treatment of psychological disorders is organized. Now, one of the things we also look at is the etiology, the causes and development of these disorders. At what age do they develop? And how often do people have them? What's the natural incidence rate? When does it develop? And so we look at sort of these historical facts because this allows us to track disorders. You know, there's like a 50% jump in tic disorders uh, in uh, in young teenage females since the introduction of TikTok in the last 3 years. And we know that because we can track how often these disorders are diagnosed. And when you see a disorder change in frequency, it is interesting for doctors. So we know that schizophrenia tends to occur around in the late teens. So it tends not to occur at 10 or 12, certainly not at 7 or 8. And so we begin to learn about these disorders as we learn the etiology, when they arise, how they arise. And if you think about that, we do the same thing for medicine. Think about it. People start having heart disease and cancer problems in their late 40s, early 50s. We know this is the typical progression of these diseases. So we know that. We can also know that about psychological disorders as well because they behave along these same principles. Now, doctors typically talk about prognosis. When we think about prognosis, we think about, is the cancer curable or not? What's going to happen in this disease? Is it chronic, or can I cure it and make this thing go away? And what happens when I take this medicine versus this medicine? This medicine cures you 40% of the time. This medicine cures you 60% of the time. So we like to know what's going to happen with a physical disease left untreated, or based on the treatments that we give them. Same thing for clinical psychology. We know sometimes, actually, one of the things that psychologists will learn is the baseline. How often does a disorder go away on its own? And when we judge treatment effectiveness, what we do is we compare the drug treatment's uh, power to make the disorder go away versus the baseline of whether or not the disorder just goes away. Sometimes, rarely, psychological disorders will come and they will go away. Now, based upon the treatment, how likely is psychotherapy to treat your depression? How likely, how effective is this drug treatment going to be for your depression? We have these numbers and we can tell how often treatments are going to affect our uh, our patients, right? And then, of course, we like to know base rates for disorders so we can know if disorders are increasing or decreasing. To give you sort of a tangential note to sort of draw you into this process, I don't know if you've read in the news recently, but colon cancer rates have really, really increased for young adults, people in their 30s and 40s. Now, the deal is we know that colon cancer tends to occur to people in their 50s and 60s. But in the last 10 years, and doctors keep track of how often this happens. And what doctors have noticed is that uh, it's now occurring at a younger age. Okay, so the etiology is changing and the incidence rate, it's increasing. And so doctors can now put out this message to the wider public saying, hey, we've noticed this increase in this medical disease. And the society at large can decide what we want to do with this information. The exact same thing happens with psychological disorders. We try to do the same thing. We try to think about them in terms of symptoms. We try to think about them in terms of when they occur, how often they occur, and then we talk about how easy it is to cure them. Are they going to be chronic and last forever? Are we going to get rid of this disorder? Or is this disorder going to just spiral out of control? So we tend to use this medical model, and it allows us to be a little more systematic in treating psychological disorders, okay? Because if you think about it, a psychological disorder doesn't really have a physical correlate. You know what I mean? When you break your bone, I can image it with an x-ray and see that broken bone. But it's hard to see depression in the brain. And so we have to be very organized in how we think about and treat psychological disorders. Now, having told you all of that interesting medical stuff and you know you're starting to think about it systematically with all these grids and check boxes and incidence rates, how exactly do you know if what you're feeling or what you're going through represents a psychological disorder? More importantly, how does the doctor uh, diagnose your behavior? If you think about it, there are a million ways to lead your life. There are a million feelings to feel at any given time. How do you know when your situation and your set of feelings goes from being just the normal course of living to being something that maybe is problematic and treatable, right? It seems super duper easy when you read about psychological disorders in a textbook. But when somebody walks in your door and starts telling you their life story, how do you, as a clinical psychologist, without the benefit of an x ray or a blood test, how do you know if someone has a psychological disorder? Now, this may seem like a hokum, but this is really the official definition of a psychological disorder. Is it's any behavior or syndrome of behaviors, okay, that causes you to be to lose effectiveness as a human being, to suffer distress, or engage in behavior that is so outlandish and odd that everyone else in the world is bothered by it. Okay, so when you walk in my door as a client, and I'm the psychotherapist, you sit down and you start telling me your story. Actually, I'll start by saying this. So, what brings you here today? Okay. And whatever comes out of your mouth is the presenting problem. Just like a medical doctor, when you go to the medical doctor, the doctor says, what brings you here today? And you say, well, I fell and broke my arm and it hurts. Boom. That's the presenting problem. When you go sit down in front of your therapist, a therapist for the first time, and they say, why are you here? Whatever you tell them is your presenting problem. And they're going to ask you to talk about it. Now, at this point, they're not looking to figure out if you're depressed or anxious. They're not looking to see if you're psychotic or this or that. They haven't even gotten there yet. Instead, they're listening for you to talk about a syndrome of behavior that meets one of these three criteria. Number one, let's say you're talking about the fact that you are so afraid of being killed or hurt by somebody else, you are so afraid of dying in a car crash that you can't get in your car and drive to work. If you think about it, what you're telling me is you're talking to me about a maladaptive behavior pattern that interferes with your ability to function. Okay. I don't know what diagnosis you have, but you're telling me that you have something that keeps you from doing what you need to do. That's a maladaptive behavioral pattern. We're going to talk. You might have a psychological disorder. On the other hand, you come into my office and I say, what's the problem? And you tell me that for some reason you just cry and feel sad and lonely every day and you just feel so bad and you're so unhappy and you don't and it bothers you and you know you feel like dying. Now you're talking to me and you're describing behavior that causes you personal distress. I haven't decided what psychological disorder you have. No. Instead, I've decided that whatever is going on in your life is causing you personal distress. Or you might come into my office, and when I ask you about your behavior, you might describe something that is so outlandishly weird and odd that everyone in your family is avoiding you, and the whole world is kind of looking at you and saying, this guy is not judging reality as the way the rest of us are. So the first step when you come into a psychologist's office is to describe what's going on, and they're going to listen for you to talk about a behavioral pattern that either bothers you, causes you personal distress that is you can't get rid of, that is maladaptive, prevents you from being a functioning human being, or some sort of behavior that is so odd or outlandish that it just doesn't fit in with society. Okay? Now, if you describe these things, we're then going to move to the second step where we start to talk about the symptoms that you might have. Okay, so if your description describes a syndrome of behaviors that causes you distress, makes you unable to function, or just makes you stand out from the rest of society in such a way that society you can't work in society, then we're going to go to the second step. Now, right below me is a picture of the cover of a book called the DSM-5, the Diagnostic and Statistic Manual of Mental Disorders. Now, this book was developed by the American Psychiatric uh, uh, Association. There is actually one called the ICD, I think, the International Collection of Disorders, that is used internationally, that includes medical disorders as well as psychological disorders. So, but the DSM is the book of psychological disorders that was developed by the American Psychiatric Institution. If you go into your therapist, they're going to have a copy of this on their desk or on their bookshelf, and they're going to have a copy of the ICD uh, 9, I think it is, on their bookshelf. And these are the books that have the collections of symptoms that describe the symptoms, the features of psychological disorders. Now, this is in its fifth revision. Okay. Its first revision came out in the 50s, I want to say. And up until the third revision, it actually included homosexuality as a psychological disorder. So this book is to a certain extent culture bound and reflects the ethos of a society. And so when we get to that idea, remember on the previous page where I mentioned deviance, deviance is a social construct. When I was saying it earlier, you might have been saying, that's how can you do that? People can behave weird, and that's their right to. This is true. The level at which you can deviate from the acceptable cultural behaviors is decided by individual societies. And this book is revised every 10 or so years to reflect the standards in how we think about behaviors. All right, so it's in the fifth revision, and basically it's a book filled with chapters full of symptoms. And these disorders are grouped by family, if you will. All right, and each chapter contains a list of the different uh, specific disorders within that family. Okay, so if you think about, there are what we call mood disorders. Okay, disorders where people have trouble regulating their mood. And you can think about these. We have major depression. We have dysthymia disorder, which is a lower level of depression. We have seasonal affective depression, which we believe is related to sunlight, variations in sunlight and its effect on people's mood. But there are a bunch of different disorders that are related to people's inability to regulate their mood. And all of these are going to be contained in a chapter. Then there's another chapter on childhood disorders that includes things like autism and reactive attachment disorder and disorders that typically happen to kids. Then there's a whole chapter on psychotic disorders, and it's going to talk about all the different ways you can be hallucinating, and there are different variations. And so this book is going to contain chapters with groupings of disorders. Now, in each chapter, it's going to contain a description of each disorder. And you know what it's going to describe for each disorder? It's going to describe the symptoms, okay, the diagnosis features. It's going to tell you the etiology, when it causes, when it occurs, and how often it occurs, the incidence rates. And then it's going to tell you how that disorder is likely to change. So for each disorder, it's going to give you these four pieces of information. So it's going to describe the disorder, tell you when it occurs, how often it occurs, and what usually happens to it. And they even talk about what other disorders are comorbid, what other disorders tend to occur when you have that disorder. All right. And so, in the sense, this book is an organized reference manual that lists all of the disease, psychological disorders, diseases of the mind. Now, here's the thing. Uh, your clinical psychologist knows a lot of these disorders, knows has become familiarized with all of these disorders as a part of their training. Okay, all clinical psychologists probably, I mean, I'm not a clinical psychologist, but I'm sure they all read this book and they all know about every one of these disorders. However, your clinical psychologist typically specializes in one or two of these areas of disorders. And so I have a friend who is a clinical psychologist over in Apex, North Carolina, and he is a child clinical psychologist. So he focuses on the chapter in this DSM that focuses on disorders that you usually see in childhood, right? And so when kids come to him, he diagnoses them for these disorders. Now, if he was to run into a child, let's say he was to meet a child, a 15 or 16-year-old child. Now, my friend typically deals with things like autism, learning disorders, childhood behavioral disorders, and these things can run up to children in your early teens. Now, what happens if he ran into a patient came through his door that was 16 years old, but he quickly realized that this child had schizophrenia. Now, since my friend focuses on childhood disorders, he knows enough to diagnose that this guy probably has a psychotic disorder. What he's going to more than likely do is refer this child to a specialist that deals with people who have schizophrenia and psychotic disorders. So, your clinical psychologist is probably going to specialize in sort of a limited area of this textbook, okay? And they are going to refer you to other specialists, just like your medical doctor would do. If you go into your heart surgeon and your heart surgeon notices that there's something might be wrong with your kidneys, your heart surgeon doesn't treat you, they send you to the kidney doc, the kidney specialist as well. Same thing with clinical psychologists, but the psychologist that you use is going to have the area of the book that they're treating you on memorized cold. So they're not going to have to necessarily look at this book. Now, when you get a diagnosis, especially in official settings like schools or clinical treatments, what they're going to do is when they write a report up to for you, they're actually going to refer to disorder numbers in this book, these disorder numbers that are listed in this book for insurance purposes. If you've ever been to a medical doctor, when you get your paperwork, you'll notice that they have little reference codes for all of their diagnosis. And this tells everybody specifically what medical or psychological disorder you have. This helps in insurance and billing purposes. And like I said, in keeping track and developing incidence rates and other baseline information, this is very important. So what your doctor is going to do when you get the report is they're going to reference this DSM by telling you what chapter and page number they say your diagnosis represents. It's going to come from this book right here. So I know you probably thought we were going to talk about specific disorders and specific behaviors. We're going to talk about that a little bit. But really, what I think people don't understand, what I think the important part uh, that I can help you learn is how they diagnose disorders. You can go out, now that you understand what I've just talked to you about, you can go out and read about depression on your own, and you'll see the themes that I'm talking about in the Wikipedia discussion that you go to, or whatever you find your your description of schizophrenia, or whatever you're interested in. Now that you know the system, the specific disorder descriptions that you read will make more sense. But again, let's revisit this just to make sure. Okay, here's the deal. And I know I've only got done 2 slides, and I've got a ton of slides. Don't worry about it. But what we do is we try to borrow from the medical model to be very systematic in how we organize and treat psychological disorders. Now we're looking what a disordered behavior is: anything that causes you stress, makes you unproductive, or deviates too far from the world. If you do, we then go into the medical process of diagnosing you. And when we diagnose you, we know if this behavior is occurring at the right time, we know how often it occurs, and we know what's liable to happen. Now, we then, yes, so, and we diagnose it using this book right here, which lists all the symptoms that you have. And this allows us to more accurately figure out how to help people who are suffering from psychological disorders. Now, next week, we're going to talk about treating these disorders. Now, in terms of identifying them, diagnosing them, you don't need to know all of this baseline information. But if you want to know how to fix a problem, you have to know what caused the problem. And that's why all this information really helps us. Now, let's talk about some disorders for a few minutes. Anxiety disorders and obsessive compulsive disorders. Okay, now some people's problems in life result from the fact that they are too anxious, and they experience too much fear and anxiety on a given day. All of you have experienced anxiety. All of you have experienced fear before in your life. If you've ever been sitting outside the principal's office like I did most of my life, you know there's a certain amount of anxiety and nerves waiting for the judgment to come down from the principal, right? So we all experience this negative state, but for some people, they can't seem to get away from this negative emotional feeling. Um, and when that feeling starts to overwhelm these people, they start to lose their productivity, and they also feel bad. If you talk to people who have anxiety disorders, what you're going to find is the thing that really sends them to the clinical psychologist is that they don't want to feel anxious anymore. So if you think about the 3 criteria of psychological disorders, you would say personal distress. In our society, in our moving, fast-paced 21st society, you hardly notice when somebody's being anxious, right? So it's not that the behavior is out of the ordinary. And some people who are anxious can be even productive. But really, a lot of times, anxiety makes people feel bad, and they want to try to get away from it. So that's why they go to the doctor. Now, there are a range of disorders that are marked by feelings of excessive apprehension and anxiety. And we'll call this family of disorders anxiety disorders. Just going to I'm not going to go through and talk about all of the disorders. If you're interested, you should do that yourself. Um, but I do want to talk about the difference between generalized anxiety disorder, phobic disorder, and panic disorder. Okay, so generalized anxiety disorder. Sometimes people feel uptight and anxious and they can't get away from these feelings, but they don't know exactly what is causing it. And if you say, hey, I notice you're nervous and anxious, why? Well, it's just everything. If you ask these people, they won't be able to put their finger on anything uh, in particular. These people are suffering from what we would call a generalized anxiety disorder. Now, each and every one of you have gone through short periods where this happens, okay? Um, but it depends on how long it lasts and how uh, how high the feelings of anxiety are. So, and I'm not putting the symptoms that you would use to diagnose this on because the test is this is not that kind of psychology class. If you're in an abnormal class, they'll want you to know the specific symptoms. But I'm not going to list the symptoms because I don't want you to think of yourself as having to know the 6 symptoms of anxiety. But it's any if you go in to the doctor and talk to them and you just are experiencing anxiety that you can't get away from and you can't point to anything, you're probably suffering from generalized anxiety disorder. Now, John Watson, the famous behaviorist in 1920, demonstrated that you could treat somebody to have an incredibly acute fear, an irrational fear related to a specific target when he caused little Albert to become afraid of white rats. Okay, now some people we know will have a traumatic experience and some sort of neutral stimulus will be attached to that traumatic event. And the person will suddenly develop this irrational fear of a neutral stimulus. Did you know there are people who have coulrophobia? They are deathly afraid of clowns. If they see a clown, it totally flips them out. There are some people who have allurophobia. My grandmother has allurophobia. She is deathly afraid of cats, right? Now, here's the deal. Some disorders, now, if you have coulrophobia or allurophobia, you're not going to get treated by a psychologist because that disorder, you can just avoid cats and clowns. However, if you have agoraphobia, if you're afraid of leaving your house, that makes it very hard to go to work, and people are often distressed by their inability to leave their house. So, a phobic disorder is marked by a persistent and irrational fear of an object or situation that presents no realistic danger. Walking out of your house presents no specific realistic danger unless you live in a war-torn nation. Walking outside of your house isn't something you should be deathly afraid of, but there are people that have that specific fear. There are people who have claustrophobia. They are deathly afraid of sitting in a room with the door closed. They are deathly afraid of getting in a car and closing the car door. They're deathly afraid of these things that we shouldn't be afraid of. If you have that, you have a phobic disorder. Now, think about this. If we were to graph the anxiety, what you would see is that uh, your anxiety disorder, your generalized anxiety disorder, is just going to have anxiety that goes like this, that's higher than normal, right? Okay, and so that's generalized anxiety disorder. On the other hand, your phobic disorder person is going to be boop. When they see the object spikes way up, then it comes back to normal. Boop, they see the object, it spikes, and it comes way back to normal. So you can think about this anxiety as manifesting it 2 ways. Is it just an overall uncomfortable level of emotional arousal, or is it this overwhelming fear that occurs in situations when it shouldn't? So this is the difference between sort of generalized anxiety and phobic disorders. Now, here's the deal. Occasionally, some people will have what's known as panic disorder. I don't know if you've ever heard of a panic attack, seen somebody have a panic attack, or have had a panic attack yourself. but there are people who will occasionally have a panic attack. So they will have this a sudden rush of terror and fear like they've never had before, and their blood pressure and heart rate will shoot up, and they will feel as if the world, they may say, if you hear talk to them, they may even describe that it feels like the world is just pressing down on them. And these people will go through a 30-second, 1 minute, 5 minute uh, just panic attack where they have just this racing heart and this incredible terror and arousal, uh, and there's no real reason or cause to it. Now, if you have it, people do occasionally have panic attacks in stressful times of their life, but some people develop what's known as panic disorder, where they will have these panic attacks regularly and won't be able to stop them. And so it's this recurrent nature of these panic attacks that makes it into panic disorder. So if you have one panic attack and go talk to a therapist, they'll probably say, you know what, you just had a panic attack, you'll be okay, let's just see what happens. If you go to a therapist and you say, you know what, in the last 4 weeks, I've had 10 of these panic attacks, then you might have panic disorder. So, if you think about it, all of these disorders, generalized anxiety, phobic disorders, and panic disorder, are three different ways that sometimes people manifest too much anxiety or arousal in ways that either make them non productive or cause them great distress, right? Do you see that? Do you see how it's tying together? So the syndrome causes this effect. Okay, and it's just three different ways they respond, three different symptom sets that describe how they respond to their environment. And if you go to the DSM or actually Google it online, you could even see the symptoms of these disorders and see how they differ a little bit. And your doctor is going to look for the pattern of symptoms that you describe and map it on to one of these three, or there are more disorders too, but it's these three disorders are the ones I'm talking about. The doctor would map it onto these three disorders. Okay? Now, if you'll notice, I didn't talk specifically about agoraphobia, even though it is a phobic disorder. But what I want to do for a moment is talk about this idea of comorbidity. Occasionally, what you will see in the medical world is that when a person gets one unique medical problem, they will get another medical problem that is completely unique, a different set of symptoms that tends to co-occur. All right. So maybe people who eat too, who don't maintain a healthy weight and eat all of these horrible things and get morbidly obese, they may have high cholesterol and they may have diabetes. Okay. Now, these are two unique events, two unique disorders, but what happens is when you see a person with cholesterol, high cholesterol, they may be more likely than the average person to have diabetes, high blood sugar as well. And so you would say that these two conditions are comorbid. They're unique, but they're comorbid. We have the same concept in clinical psychology. And the reason I tell you that is because people with panic disorder often develop the comorbid disorder of agoraphobia. All right, so these people losing control in public creates such a negative feeling in these people that they begin to develop a classically conditioned avoidance of leaving the house. And so when you go into the uh, uh, clinical psychologist with panic disorder, the clinical psychologist is also going to test you to see if you might be agoraphobic as well. And if you go look in the DSM book, you're going to see, and I may be wrong on the numbers, so if I'm wrong, I apologize. I'm not a clinical psychologist, but I think that agoraphobia occurs in 50% of people who have panic disorder. So, what that means is when you come in and describe having panic disorder, the clinical psychologist automatically knows to look for this disorder, which tends to occur as well. All right. And so, again, what I want you to think about is the scientific process behind the medical process behind diagnosing psychological disorders. Most people don't think about this process, and it's this process which separates the clinical psychologist from the rest of the world. Okay, if I stand up and say, "Hey, I'm Chris, and I have panic disorders," that's the easy part. I have the disorder. The key is figuring out what the person has if you think that their behavior meets some sort of standard. And there's a very specific process getting all the way to the disorder, okay? Or at least there should be. There should be. Now, another anxiety related disorder is obsessive compulsive disorder, right? So, difference here, an obsession is a thought that you can't get out of your head. We talk about obsessive thinking. I don't know if any of you have ever had a thought that you can't seem to get out of your head, or maybe somebody played a song that's become an earworm and you're singing that song all day long. And we laugh when you sometimes get a thought caught in your head. Now, some people have obsessive thoughts, and these obsessive thoughts may be related to danger or fears, right? I'm going to get sick and die. I'm going to get sick and die. Now, truth of it is, we're all going to die, but most of us don't worry about that every day. It's a real thing, dying, but you still shouldn't worry about it all day. But some people get that fear stuck in their head and they can't get it out and they become obsessive thinking about that fear. Oh my God, I could die, I could die, I could die. And what that causes to happen in some of these people is that they will actually that will cause them to engage in compulsive behaviors. So an obsession is a thought, and a compulsive behavior is the behavior typically that occurs as a result of that obsessive thought. So I'm going to die. Germs will kill you. I'm going to wash my hands. Boom. So I have the obsession, it leads to the compulsive behavior. The obsession, the compulsive behavior. The obsession, the compulsive behavior. And the idea is the compulsive behavior for a moment reduces the anxiety, but it comes right back. So the compulsion is geared towards making the obsessive thought go away, but the obsessive thought won't go away. So you get this combination of thinking and feeling that drives a person to engage in highly ritualistic behaviors. All right. Now, true OCD, you're going to hear a lot of people talk about OCD, OCD, I'm OCD. If you occasionally care about the order and the organization, you're not OCD. Remember, you're only OCD if it disrupts your functioning, if it causes you great distress, or looks strange to everybody. If you get a little bit uptight about how neat your car is and you and your friends laugh about it, you're not OCD. You're just being a human being. Remember, OCD would only be diagnosed if it was causing you distress or really impairing your functioning. All right. So, see, people will talk about OCD. Now, OCD typically relates to a specific fear and a specific behavior, a ritualistic behavior. There's a different type of OCD we call the obsessive compulsive personality. A personality. Now, a person with an obsessive compulsive personality is going to take this obsessive need for order and organization, and it's not going to focus on one item. It's going to sort of be a personality wide thing. It's going to affect the way they are at work. It's going to affect the way their love relationships are going to be organized. It's going to affect the way they eat. It's going to affect the way they sleep. It's going to affect the way they dress and stand in line. Some people have this need for order and organization across their entire life. And when this need for order and organization starts to impair their personal relationships and cause stress in their life, then we might say they have an obsessive compulsive personality. So do you see how we have a difference between the OCD and the obsessive compulsive personality? If we look at the symptoms, we will be able to differentiate these two disorders. Now, if you have obsessive compulsive disorder, we work on that fear and that behavior and breaking the link between that specific fear and that specific behavior. If you have an obsessive compulsive personality, then it's going to take a different kind of treatment, dialectical treatment, which is just logic and talking with someone logically. You can work through things like that. Although I will say obsessive compulsive personality disorders in general are super duper hard to treat. Obsessive OCD can be difficult too, but obsessive compulsive personality is way more difficult. Okay? Now, the why do people have anxiety disorders? Now here's the deal. Why do we care about where a disorder comes from? Well, we care about why a disorder occurs because if we know why something occurs, then that means we understand the disorder and we can fix it. I hate to tell you this, but most of the etiology that we have for psychological disorders are theories and guesses and not quite perfect. I was watching a TED talk the other day where a really brilliant person was telling me they believe in 50 years we'll know exactly what causes psychological disorders and we'll be able to fix them. I don't know. But we do have sort of clues about what causes psychological disorders. So every psychological disorder is going to have what we call an etiology, a reason. Now, why do we have anxiety disorders? Nobody knows. But I'm going to say we have three broad clues. Some people have looked at how the brain relates to our feelings of anxiety. Some people look at whether or not we learn to be anxious. And then other people who are cognitive psychologists ask the question, is anxiety just a habit of thinking, right? So what is it? Is it something in your brain? Is it something your parents taught you? Or is it just a habit of thinking that you've developed? Nobody knows, but these are three broad clues, three broad ways of thinking about the causes of psychological disorders. Spoiler alert, every time we get to a psychological disorder, I'm going to point to these three broad sort of etiologies because, again, we don't really know what causes psychological disorders. For every disorder, there's somebody trying to hunt down what in the brain causes it, what the biology is. There's somebody trying to figure out how you learn it from whether or not you learn it from your parents. And there's somebody trying to think about it as if it were some sort of informational processing habit. And I will tell you, if you've been to a cognitive behavioral therapist, they think of it as a cognitive problem. So, inherited temperament. We do know from behavioral genetics research that anxious parents have children that are also anxious, and these children are anxious as their siblings. So we know there's maybe a genetic component. We do know if you give somebody a GABA improving drug, a GABA multiplying drug, we know that they tend to relax. If you give them a Xanax, which bumps their GABA levels up, people tend to relax. So we think that it might be related to levels of GABA in your brain. Nobody knows. All right. Now, John Watson in the 1920s with little Albert showed that you can train somebody to have a phobia. So maybe your parents reinforced you every time you were uptight and anxious about a test. Maybe if you had a test and you weren't nervous, your parents would yell at you. And if you were anxious and uptight about your test, your parents would say, "Good child, that's a focused kid." And so your parents might have reinforced the behavior and caused you to learn that behavior. And now, why do we care? Here's the deal. If it's a neurotransmitter, we give you a drug, the behavior gets it better. On the other hand, if you learn it from your parents, the drug is just going to mask the problem and not fix it. So the behaviorist would say you have to unlearn the problem, right? Now, the cognitive people would say, you know what? What happens is our parents may teach us early in our life, But then it becomes a habit of thinking that we don't even thinking about, that we don't even think about. So the cognitive behavioral therapist would bring you into the lab, would expose your habit. So when this happens, what typically happens? And you, well, I think these things. Okay, great. This is the problem. Here's a new habit. And they would then teach you a new interpretational habit, so to speak. And these are sort of your treatment would be based on our belief in what causes this psychological disorder. Now, I really only talked about anxiety disorders. I've missed several slides uh, on this PowerPoint presentation. But here's the deal: I told you the important part. I told you how the system works. Now you can go and look at these disorders that I've got on the further slides, and you can figure out what they mean on your own, right? So a dissociative disorder is when you split into two personalities. You'll notice that there are two types. Dissociative amnesia, which is when you forget who you are. Some people actually forget their identity. Okay, that's dissociative amnesia. And some people will develop 3 or 4 people that they think there are. Those are differentiated based upon the described symptoms. Those are the two disorders. Okay, and then down here we can talk about the etiology, what causes them. Now we'll go to mood disorders. Okay, so you can be depressed, so the mood can go down, or you can be the kind of person whose mood swings in ways that make you feel unhappy. That's bipolar disorder, right? So we can think about it that way. Manic versus depressive episodes. So we can talk about the etiology of mood disorders. Why do we think they occur? And it's the same thing. Schizophrenic disorders, these schizophrenia. Actually, we're going to talk about that Wednesday in class. And then we're going to talk about the different characteristics. And here's the etiology of it: autism spectral disorder, personality disorder, eating disorder. The deal is, as long as you understand the system, okay, I'm looking for you to describe a set of behaviors that either makes you uncomfortable, makes you unproductive, or is so weird that it's going to make it difficult for you to fit in. If you describe that, I'm then going to listen to you tell me what your symptoms are. And I'm going to try to figure out, is the problem with your mood, or are you too anxious? Do you have too much arousal? Or are you saying things that don't meet up with reality, right? Or is it something with your personality? And then what I do is, when I figure out what those symptoms are, you get the diagnosis, and then I do this treatment based upon the etiology, what I think caused your symptoms. Does that make sense? I have talked about an awful lot in 50 minutes, and I spent a lot of time on the system and not as much time on the specific disorders. Like I said, you can read about the specific disorders on your own. The key, in my opinion, to unlocking the system is knowing why we're coming to these diagnoses that we are. If you're still online, go ahead and type me a hello. It is 9:53. It has been great seeing you. Remember this week's, this is if you're watching a recorded broadcast, this might not be for you. But for my students in the spring of 2023, our webinar has been moved from Thursday night to Wednesday night. So I look forward to seeing you Wednesday night. If you don't have any questions, I'm going to go ahead and say goodbye. Take care, and I look forward to seeing you in webinar this week. Bye.